was part of the Lancet Commission on Diagnostics, and the marquee finding was 1 in 2 people on planet Earth lack access to essential diagnostics. So if you ask me what has motivated me is I want India to end tuberculosis. If I don't become a surgeon, nothing is going to happen. Any number of my friends will become surgeons. But I should do public health as my first choice. Clinical medicine is only a fraction of what impacts health, right? Access to healthcare, inequities in access to healthcare, social determinants of health, poverty. All of those have an outsized role on the population's health.
Professor Madhukar Pai, most introductions begin with your many titles and achievements. But today, we like to meet the person beyond the epidemiologist, the medical student from India who went on not only to question diagnostics, but also at present who controls knowledge, opportunity, and power in global health. Welcome to Kasturba Medical College, Madhu.
Thank you. Pleasure to be back here.
So first of all, do I call you Professor Pai or Madhu?
Madhu.
Yes. So Madhu, your professional biography is formidable. Okay. So let's begin when you didn't have any of those titles. In medical school, was there any patient, teacher, or any experience that made you choose preventive medicine rather than treating patients at a time?
Thank you. What a beautiful question. I think for the first few years of MBBS, I was like everybody else in the sense that I wanted to become a surgeon. I was very excited about it. I used to even go into the OR as a med student. And then something happened. I had a chance to go to a place called Sevagram in Maharashtra, Varda, where a group of medical activists meet every year. That group is still alive. It's called Medico Friend Circle. I think they celebrated 50 years or something like that. And I was just like completely stunned by the people. Everybody sat on the floor several days, ate in the ashram, and there were conversations about why healthcare was not reaching rural India, why medicines were not affordable, why medical care is often irrational in the private sector. And I was like completely, my mind was blown. And I realized at that time that clinical medicine is only a fraction of what impacts health, right? Access to healthcare, inequities in access to healthcare, social determinants of health, poverty, all of those have an outsized role on the population's health. And one of the leaders of that group gave me this cartoon or an analogy, and I still remember it, and I use it when I teach. So he said, imagine you're walking into a room and the basin is overflowing with water, and water is all over the floor. What's your first response? Would you start mopping the floor, or would you turn off the tap? So of course I turned off the tap. He said that's exactly what public health and preventive medicine and community health is all about. It's not that we don't need clinical medicine, but we also have to figure out how to turn off the tap of this disease. And that's when I realized, okay, maybe if I don't do clinical work, 5,000 other people will do it. If I don't become a surgeon, nothing is going to happen. Any number of my friends will become surgeons. But I should do public health as my first choice. So as I was finishing my MBBS, everybody said the best place to do community health is CMC Vellore. So I wrote only one entrance exam in my entire life. That too, only community health at CMC. I was ranked first. I did my MD. I finished my MBBS in February. March 1st, I was a MD resident in community medicine at Vellore. And I never looked back since then. Because that place was miraculous. Yeah. I did everything humanly possible. Investigate diarrheal disease outbreak, take care of leprosy patients, take care of malaria, TB. And when I finished my MD, I said, man, I've learned so much. There's a million problems to solve. And research and epidemiology is one way to do it. That led to my PhD in epidemiology in Berkeley. And then, as they say, the rest is history. But that's the origin story. I could have become a surgeon under some other life, right? If I had a different life, That would have been a different path, but it kind of bifurcated somehow. I strayed away from clinical medicine, but I found my passion. I think today, Shrikala, compared to when I was taking community medicine, everybody thought I was crazy. Right? Even my parents, even my family thought, even my family said, "Are you going to be a real doctor or not?" Right? Today, I can see so many young people intentionally choose careers in public health. Right? There's masters in public health, schools of public health, Prasanna School of Public Health. It's a very nice, and I think COVID-19 was a beautiful case study of how important public health is. Right? Sure. Suddenly they became rock stars, right? Public health people. So I think it's a vastly better situation today than it was 30 years ago.
Yeah. Thanks for sharing that beautiful anecdote regarding the tap. You have described yourself very interestingly many times as a double agent. Trained in India but working in one of the best institutions, universities, McGill University in the global north. So you have seen healthcare on both sides. Does it make you optimistic about global health, or is it making you impatient about global health?
So, I do straddle both worlds, and, sometimes I'm most inspired when I'm in the global south, because I feel like there is any number of exciting problems to solve here. There are genuine needs here that my skills and talents. But I've made peace that I can still be where I am, but I can do much of my work here. So virtually all my tuberculosis research still happens in India. I have trained several Indians,
Yes, I know.
You and many others have come. So I feel like I can still do a good job of straddling both worlds. But my passion is to contribute here. So if you ask me what has motivated me is I want India to end tuberculosis. That alone is a guiding beacon of light. Even last week, I was doing TB work at ICMR. So I keep on doing it with the hope that would be my way of giving back to India. At the same time, McGill allows me to bring exceptional students from all over the world, including India. Some of the people I trained are now directors of institutes in India. So I feel like there is a way to give back as well. Right now, I have to say to you, given the proximity to the United States, and all the insanity we are seeing there, it is a relief to not be there, at least for a few days. Because the minute I go back, all the craziness will start all over again, because the whole environment is completely gone crazy. Here, I feel like things are still working. There everything looks so uncertain. So there are times when I am happier to be here. There are times when I say, okay, maybe I should not give up on the global north yet. There is still work to be done there. So I think one has to find some way of resolving the tension between this constant pull between those two parts of one's life.
So let's go to your passion on laboratory testing and tuberculosis, of course. So many times when a new test arrives, we are from diagnosticians, microbiologists, pathologists, we are very excited about it. Technically, the test is excellent, but many times it does not translate to a patient being diagnosed or a life being saved. What do you think is the gap between this? A great test, but not actually being useful on the ground.
Yeah. So, my PhD thesis when I was in California was on TB diagnostics. So since then, I've continued to work on diagnostics, not just for TB. I now have learned that it's not enough to only detect one disease.
Correct.
Because the same person could have diabetes that is undetected or HIV.
True.
So I have a broader understanding of what I call diagnostics in global health. And I was part of the Lancet Commission on Diagnostics, and the marquee finding was 1 in 2 people on planet Earth lack access to essential diagnostics. 1 in 2. Even if today, if you go to a PHC in many parts of the world, you will not even find a glucose strip. You will not even find a weight and height. Right? TB patients can't even get a BMI measured in many parts of the world. So diagnostics is a deeply neglected area, which as a microbiologist, and it's obvious to you, but it is not. That is why so many clinicians are practicing empirical medicine, uninformed by what they're treating. They're treating for a broad variety of conditions and scattershot therapies. And we've seen that with multiple diseases. It's very hard to achieve precision-based medicine if you can't even detect, right? So to me, we have great tests in this world. Access is where we are failing. It is not easily available to people where they need it the most.
Is it because of lack of political commitment, or is it because of just human behavior? I needn't get myself tested, just give me some medicine. That's what generally happens.
You see, during COVID-19, suddenly testing became so important, right? People did all sorts of things to make testing widely available. India alone did, billion PCRs, right? Yeah. So when we needed to, we found a way to make it work. Why can't we not do that for fevers or respiratory infections or viral diseases? Anything that is informed by a diagnosis will be a better form of medicine, right? Empiricism sometimes is the only thing we can do, but I don't think that is the right way to practice medicine under most circumstances. We wouldn't want it for ourselves, right? True. If I had fever and you think I have typhoid and you don't even bother to confirm it, I could easily become drug resistant, right? I want something a lot more nuanced. And today, I think it's possible. We have amazing molecular tests for a variety of diseases. We have sequencing. We have crazy technologies, but we have to figure out the access problem. That is where I think we are not doing well. Yes, there are simpler AI-based detection tools and all that coming on board. There may be a way to get out of this expensive ways of doing things. But I think it's a very exciting area of work to make essential diagnostics available for all.
Because we have seen TB diagnosis grow from just a simple microscopy to the advanced molecular test, and not only that, advanced molecular test which has been deployed in the public.
Absolutely.
So that is really, amazing, and probably,
absolutely,
it could lead the way.
And in a few weeks, the world will have a $2.50 tongue swab based molecular test available and scaled up in many, many countries.
I was just going to ask you that. What is one innovation in tuberculosis that genuinely excites you?
I think about 15 years ago, I think the Gene Expert test was a breakthrough. We all saw it, we used it, but it was still expensive. It was still difficult to deploy at the primary care. And 15 years later, we now have a small point of care molecular test, which can be done with sputum or tongue swab at about $2.50 per test.
Would it be deployed in India? Or?
Oh, yes, it's already coming.
Look forward to it, So, where do you think India has made genuine progress in terms of tuberculosis? Are we still telling ourselves a more comfortable story than the evidence actually states?
Definitely, India has made progress in the sense the burden has come down. But where I think India's progress is most visible is there is now genuine political commitment.
Okay.
Right from the Prime Minister's office, it's being reviewed. That means there is scrutiny and therefore everybody is responsive. India has definitely invested more domestic money. India takes very little donor monies for tuberculosis. That is way different from how it was in the past.
So we have not been affected by the American...
not affected by the USAID and all of the US cuts. India has invested massively in social benefits, that like direct benefits transfer was quite a revolutionary thing, right? 1,000 rupees a month. I think, and that has had multiple benefits because when you address poverty, TB automatically responds to it. It's a very sensitive disease to poverty. India has scaled up molecular testing, still not complete, but come a long way. India now has 6 months all oral BPAL and BPAL-M for drug-resistant TB. So in every way, I think India has moved forward. But where I think India has to do better is that I still think undernutrition and poverty are huge drivers of TB, right? And so we have to get past that widespread undernutrition. And so anything we can do to tackle undernutrition is turning the tap off.
True.
If you ask me how to turn off the tap in India, I would put undernutrition as my top work and one of your professors has done amazing work in that area, Dr. Anurag Bhargava and his wife Madhavi. So lots of work happening in that area. I think India absolutely should make molecular testing as a frontline test for TB. I'm not a fan of smear microscopy in this day and age. We still need microscopy for treatment monitoring. But for the upfront diagnosis, India should 100% transition to molecular testing.
So it's there in the algorithm,
it's there, but it's not widely deployed. Yes. But it's getting there slowly.
Do you think AI will help somewhere in the scheme of things?
AI is endorsed for digital X-ray reading. So Indian government has scaled up digital X-rays and AI solutions in multiple places, including the 100-day mission for active case finding. PHCs now have, some of the PHCs now have digital X-rays, and they are all read by the AI algorithm. So image recognition is where AI is killing it, meaning it's really good, right? But there are other potential, for example, cough applications that are being evaluated. Can you use cough sounds and AI to screen for TB? Can you use lung sounds and AI to screen for TB? Those are not mature, but what is mature is digital X-rays and AI. That is already deployed.
As a researcher and a journal editor, what is one avoidable mistake that repeatedly weakens otherwise valuable research from India and the global south?
Sometimes I think that the manuscripts that I see from India, the quality of English tends to be a little weaker than I would like it to see, right? Or there is some sloppiness in how we write, which does not make us pass the initial screen. Okay. Second thing is we don't advocate for our work very well. We just submit it. But in many parts of the world, you first contact the editor. You email the editor and say, I have an exciting study. This hasn't been done before. Or we have a huge series of melioidosis. This is not a disease that is seen in other parts of the world. We have the largest series. And this is an exciting area for your journal to consider. One has to promote one's ideas and be a little proactive about it. You just can't submit it into the online system and hope that everything will be okay. It's fine to make an effort. And most journal editors are like that. They want to know what is coming. Why is it important? In other words, we don't make a case for why our work matters. Why does it belong in the Lancet? We're not able to make a convincing case. We think our work speaks for itself. Sometimes it does not. We have to advocate for it. And that's why one should never hesitate to write to editors and say, you're the editor of Journal of Clinical Microbiology. We have this wonderful study in a difficult, challenging environment where we've looked at this, that, and the other. Would you be interested? Would you consider this public manuscript from the Global South? In other words, explain to them why they should think about it and why it has links with poverty or access or other things. And then they might get excited and say, okay, now it'll go out for peer review. Otherwise, it even get test rejected.
Right. Okay. That's something nice and new that we've heard today. What can institutions like MAHE contribute to global health that universities in global north may not be able to produce?
I mean, what am I going to do on tuberculosis in Canada, right? We don't have a lot of TB. So you have incredible, clinical skills. The disease burden is here. And I think this is where some of the most exciting work can happen, right? So, and MAHE has made very important contributions, melioidosis, KFD, tuberculosis. So there is a lot of areas where I think you can make an amazing impact. And also the volumes that you see is simply unthinkable, like we were just discussing, Wenlock and your public hospitals. So there is enormous richness here, but it requires serious rigor in research, right? If you're just doing research on the side along with the full clinical load, then you can at best come up with a case series. But could you actually do an intervention? Could you do a field-based study? Could you do a very large study? Could you do a follow-up study, which would be more meaningful rather than a cross-sectional study? So I think we can afford to migrate to more sophisticated research studies and ask more nuanced questions. if we treated melioidosis with this new medicine, could it potentially have an impact? Suddenly, you're looking at a paper in the New England Journal of Medicine because it's groundbreaking. Like that scrub typhus randomized trial by Bellor in New England Journal, because that is not a disease that the rest of the world sees much, but they actually intervene. And they showed what the drug does. Suddenly, you're worthy of a high quality paper that can totally transform the landscape for that particular condition.
So now going to the next session about for the students, teachers, and future leaders with your vast experience. Students are repeatedly told to find their passion. You found your passion. But here many are still trying to pass exams and satisfy their families' wishes and at the end of the day secure a postgraduate seat. So how does a young doctor actually discover this sense of purpose in the middle of all these things?
I genuinely think if they see good role models, they are extraordinarily inspired. That's what happened to me. I was very lucky to see, like when I went for those meetings, even at Bellor, I saw incredible role models, right? So anyone who's passionate about their work will exude that passion to others, and you say, I want to be like that person when I grow up, right? So I think if you could also expose your students to send them to inspiring places. For example, there are amazing projects all over India, like the Bilaspur team, the group in Sitilingi, right? There are interesting, amazing work happening all over the world. You can send them for short week-long rotations, like Gachiroli, right? Places where they will say, oh my God, such interesting work is happening. Not all of them will care to follow that path, but they'll come home thinking that I have seen incredible people on the ground doing incredible things. I want to be like them when I grow up. I think there are abilities now to offer them those sorts of field exposures that will change how they think about medicine.
Do you see a change in the medical colleges now from the time that you were studying? Has something changed on ground? Because you visit quite a lot of medical colleges.
I think young students now have a lot more easy access to everything, right? Like medical literature, up to date, and online information, AI. Everything that they need is on their phones. But I also worry that they're no longer talking to patients anymore or spending time at the bedside. We had to learn it the painful way. And I think they're getting kind of dissociated into this virtual world and not engaging enough with the real world. There's any number of real problems to solve, and it's easy to retreat into that world. So some progress in some ways, but that it also, I think, comes at a cost.
Could you tell us about one rejection, failure, or criticism that changed the direction of your career more than any award did?
I think, when I was doing my MD, I did a lot of research studies that didn't work well. And some of them bombed spectacularly. I even wrote a piece on all the research failures I've had in the British Medical Journal as a letter, because I think what it did for me, as spectacular as those failures were, it made me very humble by the time I reached my PhD. So then I knew what I needed to learn. I knew where I had failed before. Even simple things like, for example, when I was at Vellore as a resident, they told me, you have to go to this village and you have to complete this survey, right? I thought, as an MD resident, I knew everything. So I went to the village. So one of the first families I interviewed, there was a woman who looked very old. So I asked her, for the form, how old are you? She started laughing. I said, what have I done? She said, son, in Tamil, she said, son, you look at my face and you decide what my age is and you put it down, because I have no idea what my age is or my birth date is. I went running back to my professor. I can't even get an age. How smart a researcher can I be if I can't even get age in my survey form? So then my professor came and said, take me to him. I had an amazing professor called Jai Prakash Mulia, one of India's foremost epidemiologists. He said, take me to this lady. So he spent 10 minutes decoding what her year of birth could have been. He said, when you were young, had India achieved independence? How old were you when the great flood happened in this area? So with 8 or 9 questions, he finally triangulated that she's only 55, even though she looks 85, because poverty ages you, right? And I said, this is a master class on how to collect age as a variable, which I could not as an MD resident. It was humbling, but it taught me that even something simple as age cannot be taken for granted.
True.
You can misclassify someone's age, right? How many vaccines have you had? I don't know.
Mhm.
You look at my scars and you figure out I don't have a vaccination card. So even things that we think are rock solid cannot be taken for granted. And those are all lessons that I took into my PhD.
Great. You have spoken about polycrisis quite often. Pandemics, conflicts, climate change, misinformation. We just spoke about vaccine misinformation this morning, and widening inequity. How do you remain hopeful amidst all this?
I think whenever things are bad, I wouldn't deny that, especially in the North American context.
Mhm.
We have kids dying of measles and diphtheria in this day and age, which is just catastrophic. Should not have happened. The diseases that I did not see as a resident in Vellore, kids are dying of today, which means something's gone wrong, right? Public has lost their trust in public health, or intentionally people are spreading disinformation. So things are bad, but I still think hope can be found. Like, for example, young people are leaders now in many ways. For example, in climate change, even if the leaders, the political leaders are giving up on acting on climate change, young people are demanding that we address climate change because their futures are
Depends
being
on
compromised, right? Look at all the devastating wildfires in many parts of the world, the flooding. So I still think that investing in young and letting them lead is one way to find hope. And all the young students that I teach, they are depressed about the state of the world, but they're also not willing to give up, because if they gave up, there is no future for them. I think our generation could have done better.
Mhm.
We could have done more to prevent some of these polycrises, but we've now put them to shoulder the burden, which I think is challenging and problematic. But I think we should trust them to do more, but still work with them. We can't just bail out just because we are not young anymore, right? We still
Your
have an
hope is
obligation.
the next
The
generation.
next generation.
So, Madhu, some rapid fire questions for you. So, here they go. One myth about tuberculosis you would like permanently retired.
That it only that is a disease of the past. A
Oh.
lot of people still think that it's gone. That's not true at all.
One subject every medical curriculum should teach better.
Communication, how to even talk to people and write with clarity.
One book or article every medical student should read.
There was this amazing book in India. I would say there is this phenomenal book called Raku's Story by a Canadian professor, Sheila Zubrig, who came and worked in Tamil Nadu. And she wrote the life of this girl called Raku. And I'm talking about 40 years ago, 50 years ago, she wrote that. That was one of the earliest descriptions of why Raku's child became sick. Not because of the bacterium or virus, but all of the reasons why she was poor, why she couldn't access healthcare. I think that book is truly groundbreaking, and it's still available.
Okay. One quality that distinguishes a good mentor.
I think the best definition of mentor I've ever read in my life is in a New England Journal article, which says something like, a real mentor has more imagination about you than you have about yourself. In other words, they see greatness in you that you haven't yet seen. And that's why they mentor you when you are a nobody, right?
Excellent.
It's easy to mentor when you've achieved something, right? But they see something in you and they back you even if you're not seeing it at that time. I think that's a beautiful trait in a mentor.
One public health achievement by India that deserves more recognition.
I genuinely think some of India's biggest wins have come from institutional deliveries to reduce maternal mortality and child mortality. I mean, in the past, a lot of moms and children would die, which is very rare to see that today, which I think is a wonderful achievement.
One fashionable phrase in global health that you would happily ban.
Capacity building, right? In other words, the global north thinks that they need to build the capacity of the global south. But this is where the capacity is, right? This is where enormous wisdom is if you're willing to learn from it.
Clinician, epidemiologist, teacher, editor, or activist, which identity feels most like you?
I think I would happily say teacher as my number one passion. I could give up every other aspect of my life.
I can imagine that, yes. What helps you switch off from work?
I don't.
You never switch off.
My wife and daughter will tell you.
So the next question, your secret to work-life balance.
I have no work-life balance.
So you work and Nitika and Anita do the balancing act.
I think my dog allows me to switch off. She is a wonderful golden retriever. So when I'm with her, I forget about everything else.
2 reasons why you love to come to Mangalore.
Ponozu, mangoes, and of course my family.
What would the 23-year-old Madhu Pai be most surprised to learn about your life today?
At that age, my dad had died when I was in high school. So we went through a really bad patch, economic crises. So, it was a rough time. But I think I would have been happy to know that it would be okay in the future.
Nice. So the last, after all the publications, programs and leadership positions, what would make you feel that your work has truly mattered?
I think all the people that I have trained everywhere in the world that they are working now, I actually see them now. In other words, when I go to some country, I look and see if I have my former students there, and I track them down and I take them for dinner.
Forward your legacy.
Exactly. I think that is the best reward, right? You see people thriving and doing the work that makes you feel like you've done something good. Right?
Thank you so much, Dr. Madhukar Pai, for this very insightful podcast. I'm really sure that it would have motivated a lot of others to follow your inspirational journey. Thank you so much for being here.
Thank you for being an amazing host. Thank you.